Unfortunately, over the years, bacteria have become increasingly skilled at resisting our current antibiotics. They're like bandits who keep figuring out ways to escape the sheriff. The two most common and deadly resistant bacteria are methicillin-resistant Staph aureus, or MRSA, as well as vancomycin-resistant enterococci, or VRE. Do you remember the first-line treatment for an MRSA infection? That would be vancomycin. And how do bacteria develop resistance to vancomycin? Remember, the dealanine-dealanine dipeptide of the peptidoglycan cell wall is mutated to dealanine D-lactate, and therefore vancomycin does not work. When vancomycin doesn't work, daptomycin, ceftaroline, linezolid, or tigecycline are options for treatment. A mnemonic to remember this is very dangerous cocci loathe treatment. Vancomycin-resistant enterococci, or VRE, is a type of group D streptococci that is treated with streptogranins dalfopristin, quinipristin, as well as linezolid. A way to remember this is that VRE don't quite like vanco. Now time for a flash quiz. What medication is used for prophylaxis against endocarditis associated with dental procedures? Amoxicillin is used to prevent virulent streptococci endocarditis. Virulent streptococci endocarditis is the most common form of endocarditis associated with dental procedures. This is because virulent strep is commonly found in the oral cavity, and during trauma in a dental procedure, the bacteria can enter the bloodstream and attach to a previously damaged heart valve and cause a clinically significant endocarditis. Before we talk about the individual antifungal therapies, let's spend a minute or two talking about the fungal cell structure and how it is the same and different from bacterial and human cells. First, let's compare and contrast fungal cells to bacterial cells. The first big difference to recognize between fungi and bacteria are that fungi are eukaryotic, while bacteria are prokaryotic. What is the importance of this? Well, for starters, every drug that we talked about in the antibacterial section will not work against fungi. But besides that, do you remember the main differences between fungi and bacterial cell structure? Well, fungi are larger, ranging from 4 to 5 microns, while prokaryotes, or bacteria, are about 1 micron. Fungi have a nuclear membrane, bacteria do not. Fungi have distinct organelles, bacteria do not. Fungi use 80S ribosomes, while prokaryotes use 70S ribosomes. That is a pretty good list. Now, so what are some things that fungi and bacteria have in common? Well, for starters, they both have cell walls. Now, do you remember what the cell walls are composed of in bacteria? That is peptidoglycan. Very good. Now, fungi are composed of cell wall that includes chitins, chitins, glucans, and manads. Very good. Now, I want you to keep this in mind as we continue to talk about the antifungals. Now that we know that fungi are eukaryotes, you might be wondering, aren't human cells eukaryotic too? What molecular therapies do we have that only affect fungal cells while leaving human cells alone? That is a very good question, and to best answer this, let's do what we just did and compare human cells to fungal cells. The key similarities between human and fungal cells is that they're both eukaryotes, they both have distinct organelles, and they both use the 80S ribosome. Very good. The key difference is that fungi are haploid and human are diploid. 2. Fungi have cell walls, human cells do not. 3. The fungal plasma cell membrane are made primarily of ergosterol. The cell membrane is made up of ergosterol, while in humans it's primarily made up of cholesterol. Fungi have an enzyme called cytosine deaminase that's unique to fungal cells, and it has a squalene epoxidase. And the microtubules of fungi have affinity for a drug called griseofulvin. These are the key differences between fungi and human cells. By recognizing these differences, we are able to target just the fungi and not kill our human cells, which is very important when we talk about treating these fungi. Before we start talking about the individual drug therapies, I want to briefly review the clinically important fungi that these drugs are used to treat. The way I like to break up the clinically relevant fungi is by organizing them similar to the way your first aid text does, into systemic, opportunistic, and cutaneous mycoses. So for a little review here, the 4 important systemic mycoses are histoplasmosis, blastomycosis, coccidiomycosis, and paracoccidiomycosis. Remember, these fungi are endemic to certain regions of the world. Do you remember what geographic regions we can find these fungi in? Well, histoplasmosis is found in the Mississippi or Ohio River valleys. Blasto is found in the eastern United States or Central America. Cocci is found in California and the southwestern United States. And paracocci is found in Latin America. Very good. The 6 important opportunistic fungi are Candida, Aspergillus, Cryptococcus, Mucorrhizopus, Pneumocystis, and Spirothrix. Do you remember what it means to be an opportunistic infection? It basically means that these fungi seize an opportunity to cause disease in a host. The most important clinical example of an opportunity is when a patient is immunosuppressed. In patients with healthy immune systems, these fungi do not cause disease, but when there's a form of immune suppression, like in AIDS or in chemotherapy or even in severe malnutrition, these fungi can cause significant and serious disease. And finally, there are the cutaneous mycoses. They all start with the word tinea and represent the part of the body where they cause infection. There's tinea capitis, corporis, cruris, pedis, inguinum, and versicolor. Here's a diagram from first aid that puts all the antifungal therapies onto an organized schematic of the fungal cell. We can see there are 5 strategies for killing fungal cells with medications. Namely, we can interfere with linosterol synthesis by inhibiting squalene epoxidase. We can mess with ergosterol synthesis by messing with 4-alpha demethylase. We can also inhibit nucleic acid synthesis, Flucytosine. We can disrupt membrane competency with the polyenes, and we can interact with the cell wall synthesis with the echinocandin medications. Now that with this nice general overview, we can start talking about each medication individually. First, we're going to talk about Amphotericin B, which is a polyene that binds to ergosterol in the cell membrane and forms membrane pores. Remember, ergosterol is a sterol that is unique to fungal cell membranes. Do you remember the sterol that's found in human cell membranes? That's cholesterol. Very good. We can see here that by forming pores in the cell membrane, it gives an avenue for all the precious electrolytes to exit to the cell. An important concept in cell biology is wherever sodium goes, water follows. As water and electrolytes leave the cell, the fungal cell will die. You can remember the mechanism with the mnemonic Amphotericin, which tears holes in the fungal membrane. Clinically, Amphotericin B is a powerful and life-saving drug. It is effective against all of the systemic and opportunistic mycoses, including histo, blasto, cocci, as well as disseminated Cryptococcus, candidiasis, and mucormycosis. Do you remember the life-threatening infection caused by Cryptococcus? Well, Cryptococcus can cause cryptococcal meningitis. If there's cryptococcal meningitis, Amphotericin B is given intrathecally into the cerebrospinal fluid. Do you remember which meningeal layers the CSF lies between? It is in the subarachnoid space between the pia and arachnoid mater. Very good. Now I have 3 images of fungal mouths that I want to show you and have you identify. These are high-yield images that very well may come up on your Step 1 exam. Picture number 1. What is your diagnosis, doctor? This is mucor. Very good. Now how about this one? This is Cryptococcus neoformans. You can see the yeast cells with a thick capsule, which is unique for Cryptococcus neoformans. Now how about this one? Here we can see coccidiomycosis, particularly the endospores inside the spherule. All these endospores soon enough will be coccidiofungal spores when the spherule erupts. As we talked about, amphotericin is a life-saving drug. It is a heavy hitter. However, whenever there is an upside, there is usually a downside. The downside of amphotericin is that its adverse effects are very, very bad. In fact, it is also known as amphoterrible to describe how bad the toxicity is of the drug. With that being said, if you are on the verge of death from cryptococcal meningitis or systemic histoplasmosis, I would be willing to bet that many patients would weather the adverse effects. I sure would. The most common adverse effects are severe fever and chills, hypotension, nephrotoxicity, arrhythmia, anemia, and IV phlebitis. Now, do we remember what IV phlebitis means? It means that administering the drug causes inflammation of the vein at the IV site. Imagine a football team running out of the locker room for a game, hitting and pounding on the walls of the hallway leading to the field. Now picture amphotericin, like the football players, doing the same thing as it comes out of the IV line into the vein. It's hitting and smashing the venous endothelial cells, causing inflammation. And what can happen as a result of this? Well, the hallway, or the vein, can come crashing down and seal off the IV site, and the patient won't be getting the drug. In order to help reduce the terrible side effects of amphoterrible, it can be given in a liposomal formulation. So what is a liposome? Well, here's a schematic of a liposome. Try to think of it as a miniature cell. There's an aqueous center where the drug resides, as we can see here, that is surrounded by a fatty acid lipid bilayer, as we can see here, the bilayer here. The liposomal formulation is given to reduce the side effects of the drug. It is used with other medications to slow down metabolism, but for amphotericin B, it is used to reduce the side effects. Nystatin is a polyene, just like amphotericin B, and shares the same mechanism of action. It forms membrane pores. It is very toxic medication, and therefore, it is limited to topical use, meaning it's just used on the skin. It is used to treat local fungal infections, including this common fungal infection seen here. What do you see in this image? Well, this is an image of oral thrush. Now, very good. What fungi causes this infection? It is caused by Candida. Very good. For oral thrush, you have your patient swish and swallow the preparation so that it bathes the oral cavity. Thankfully, it is not well absorbed and doesn't cause systemic toxicity when it reaches the gut. It can also be used to treat very bad diaper rashes, as we can see here, that are usually caused by Candida as well. Now let's discuss the drug Flucytosine. This antifungal drug inhibits fungal nucleic acid synthesis. The key point for Flucytosine is that it is converted into 5-fluorouracil by a cytosine deaminase that is unique to fungal cells. If we remember back to hematology, 5-fluorouracil is a chemotherapeutic agent. Do you remember how it works against cancer? 5-fluorouracil is a uracil analog that inhibits the midylate synthase, a key enzyme responsible for converting uracil into thymidine. This is the same way that flucytosine works to kill fungal cells. Flucytosine is converted to 5-fluorouracil by cytosine deaminase and impacts the midylate synthase in the fungal cell. Without the midylate synthase, there is no ability to make the thymidine monophosphate, and the fungal cell is unable to replicate. So why doesn't this drug affect our own human cells the way that 5-fluorouracil does against cancer? Well, it's because our human cells do not have the cytosine deaminase, so there's no way for the flucytosine to be converted into 5-fluorouracil in our human cells. This drug is used for systemic mycoses and is used in combination with amphotericin B for cryptococcal meningitis, most importantly. Unfortunately, nothing is perfect, and flucytosine can still impact our own rapidly dividing cells and behave like other chemotherapeutic agents. Although it can cause some nausea, vomiting, and diarrhea, the most important effect of this medication is bone marrow suppression, because remember, flucytosine is a precursor to a very potent chemotherapy, 5-fluorouracil. Now we're going to talk about a very important class of antifungal medications, the azoles. All of the azole drugs end in azole include clotrimazole, fluconazole, itraconazole, and ketoconazole, just to name a few. These drugs work by inhibiting ergosterol synthesis. Let's take a moment to review the ergosterol synthesis pathway. The first step in the pathway is the conversion of squalene to squalene epoxide by squalene epoxidase. Next, the epoxide is turned into lanosterol, which is then turned into ergosterol by 14-alpha demethylase enzyme. The azoles work by inhibiting the 14-alpha demethylase enzyme and stopping ergosterol synthesis. Clinically, these drugs are very common and used against local and systemic mycoses, as well as candidiasis, and fluconazole has the ability to cross the blood-brain barrier and therefore can be used to treat cryptococcal meningitis. Another important thing to know is that 14-alpha demethylase is a cytochrome P450 enzyme, so you can imagine that these azole drugs also inhibit liver cytochrome P450 enzymes as well. In addition, ketoconazole has been known for inhibiting an enzyme involved in testosterone synthesis, and therefore has been associated with gynecomastia, as we can see in this image. Now time for a flash quiz. How is flucytosine activated in fungal cells? What is it turned into, and what enzyme does it inhibit? Flucytosine is activated by a cytosine deaminase that is unique to fungal cells. It is turned into 5-fluorouracil, an enzyme that inhibits the midylate synthase. Remember, flucytosine does not work in a human cell because the human cells do not have cytosine deaminase.